the number of the 20, 50, 80 people that you are gathering to see, and you're able to make changes, because that may be difficult to achieve, given that I've attended many outreaches myself, believe me. But if you're able to save two lives from the things you're going to tell them, that outreach is a huge success. I kid you not. So now, things that would make the airway, the pipe to be blocked, the pipe that take oxygen air to the lungs or water to the tank, as the illustration we've been using is, we call them allergens. So those allergens are triggers that would cause this blockage. They include dust, they include pollens. So in the dry season where everything just fly around and the air is dry, you see breeze, very, very windy environment, carrying dust all around the place. Those are things that would trigger. What happened in asthma? Like, the airway is very, very sensitive. I mean, small thing can go. Normally, the dust or pollen, you and I that are not asthmatic, or someone that is not asthmatic may inhale. An asthmatic person can inhale that dust, and it just triggers and make the airway excited, and it start dancing and closing up. If you get what I mean. So it just start closing up. So we have dust, we have pollen, we have pets, like people that keep cats, people that keep dogs. The force from them, they are these are very tiny, small particles that could just go through the nostrils without you even noticing and go and cause obstruction of the airway. So people having rugs in their house, rugs are about dust. So those are some of the things that are easily frying things. Like, some of them, their parents are at home frying things. So I'm guessing you can infer from what I'm saying and be picking up things to counsel them. So going to rural area, I could tell them things. These are some of the triggers that cause, after understanding what asthma is, these are some of the triggers that could trigger an asthmatic attack in your child. If the child is at home in an environment where they're frying things, that means Mama John, that meat must fry very, very well. If it's not dry, I will not eat it. No, Papa John, this is not the time to be frying meat very, very well for you to enjoy when you know you have an asthmatic son. No. The ground is cold in this house. Let's get a good rug. Some of all those, we all know that if rug is not properly clean, it absorbs dust, and we are in the dusty part of the part. Well, it gets dry in some part of the year, and those dust. You just see a child keep having recurrent asthmatic attack. They are wondering what it is. Meanwhile, they have a rug in their sitting room, or a rug in the room that, as you are sweeping it, you raise dust every single time. Or the kids will be playing, jumping up, they raise dust. That will trigger recurrent attacks in such children. Child have asthmatic attack. That's when Mama John decides she likes cats. Oh, I like my cat. The force, those animals drop their force all over the place. Small fan or small breeze can raise it up and trigger an attack in them. Pollens, going to farm, we are harvesting all these flowers. Some pollens from flowers. These are things that could trigger some of all these things. Extremes of temperature. I mean, when temperature is really, really cold, the body shivers. As the body is shivering, it can just make the airway excited and decide to close up. When the temperature is hot, these are things. So the two extremes of temperature can trigger an attack. So these are just some of the possible things that could trigger an attack in these asthmatic children. Now, how do we identify these attacks in these asthmatic children? Is what I want to say. So we've talked about what is asthma itself, like in the layers of them. We've talked about the things that would trigger the asthmatic attack in these children. Now let's talk about how do we know a child is having an attack? So some of the signs and symptoms you may see that may show that a child is having an attack is breathing difficulty. You just see the child will not be able to breathe. I don't know if any one of us has seen a child with asthmatic attack before. You'll see they can't. I mean, something like a gasping respiration like that. They are struggling to just drop the airway. The pipe that is taking water to the pumping machine is getting water from the pumping machine to the tank is getting blocked. The pumping machine keeps pumping water from the well and supplying it with huge force. But meanwhile, the lumen is not patent for the pipe to take water. So you will see the pipe. There is going to be a big struggle between the pumping machine, the lung itself, and the pipe. So if only such a person can calm down and relax and think about what is going on and take deep breaths gently, it's not going to be easy. That's the truth, because everybody is scared for their life. It's a very, very panicky situation. So if the person can calm down, relax, and synchronize that thing, relaxation is. So I'll start talking about treatment gradually, but sorry for moving like that. I'll go back to how to identify those attacks. So relaxation go a long way in helping. So, but back to how to identify the attacks. Breathing difficulty, you start hearing there's a sound that when we call it wheeze. Don't worry about all those ones. But I mean, when a child is having breathing difficulty, you see the child panicking, raising the hand and beating the air, flailing the air, like, oh, help me, what's going on? In a non-asthmatic suspect, that person is having an attack. The person may not be able to complete a full sentence in one breath. See the way I'm talking now? Hi, my name is Olaide. You hear an asthma, you may hear something like, hi, name, because he's just struggling to breathe and talk at the same time. So he will not be able to complete the sentence in one breath. So there's something we call trachea tugging. So if you look beneath the skin in your neck, you may see there is a trachea that goes down there. It may be pulled to one side in an asthmatic attack. But I mean, in an emergency situation, it's not that time you will tell the mother to be looking for trachea that is tugged in a child that is not breathing well. So let's not too dwell on that. So there could be cough. The child could be having it could just be coughing, incessant cough, just trying to catch his breath, doing everything. These are survival instincts that are kicking in. The child could look confused or exhausted. The child has been struggling to get it. Once the child starts, that's bad. That's really, really bad. That's getting to the extreme. The blue turning blue. So it's just like in the body. We have blood so everywhere in the body. And when blood is getting oxygen, it turns red. Once blood is start getting dark, it starts getting from red to blue. So our lips is well vascularized and well supplied. A child that you see turning blue suddenly, it's just due to lack of oxygen. What is making the child turn blue is not the asthma, it's lack of oxygen. So, but what is causing that lack of oxygen is now asthma, if you get what I mean. So, some of the things I've said, how to identify that a child is having an attack currently. I say breathing difficulty, cannot complete the sentence in one breath. The child may be coughing or having wheeze. Trachea tugging, which I say should keep down the list. The child can look confused or exhausted, just behaving irrationally. Like, oh, there's something going on. Then the child can have blue lips. The color can just begin to change. If it were to be an adult will have sense to even show you that he's having an asthmatic attack, or run to mom and be beating his chest or make some motions that will make the parent to get the vibe that this is what's going on. But I mean, a child, you may not see anything. Children will not tell. Is a 2-year-old, 3-year-old kid will not tell you, "Mommy, I'm having an asthmatic attack." We'll just be panicking and crying and on the floor rolling. So you may not be sure. That brings confusion. Is this child choking? Is this child having an asthmatic attack? So it's difficult to identify it in those age groups. But if you have a high index of suspicion and you are on the lookout for something like that, it helps you to pick it. One thing that is also very important to note that I should have mentioned in etiology, I think, is there is a strong genetic predisposition to asthma. I've talked about genes. So when I say there is strong genetic predisposition, in a family history where there is asthma, and you see a child having recurrent respiratory illness as a child, that child should be taken to the pediatrician for assessment to make a diagnosis in the child if there is likelihood of asthma, or if the child has asthma in that child in that place, or if the child has asthma. It's very, very important. There's a test called spirometry. It helps us make definitive diagnosis of asthma. Sadly, I know the way things are with us home, it's maybe difficult. I know people run away from hospital, but no. And again, the bureaucracy of some of the hospitals. So it's not all the hospitals that can do spirometry. I mean, you may basically in Ondo State, you may not see any place where they are doing spirometry unless a teaching hospital. And please, I'm sorry, no pun intended. Don't count University of Medical Sciences in Ondo town itself. With the equipment may not be there. It's a good place, but I mean the equipment may not be there. So places where you'll be getting things like spirometry, you may have to go to the big centers, OAU, you may have to go to Ilorin, you may have to go to Lagos, you may have to go to Jos, you may go to, if you get what I mean. So it's that health seeking behavior is another thing. People have some preformed notion, but I think it's worth it really to make a diagnosis for your child so that you know how to take care of this child better. It's worth traveling to places or where the facilities are available to make some of all these diagnoses. But anyway, let me not derail. Back to the point I'm trying to make. So getting to the hospital to make this diagnosis is very important. Then I've talked about the signs and symptoms. So in a person having an asthmatic attack, what do we do? What are the first 8 things to do? I'll give you a story. So when I was in med school, there was this one of my teachers. His name is, I think, I can't. Dr. Jones. I think he was an endocrinologist. So he was just telling us the story that he finished med school, the first doctor in his village. They've done induction, party rice, they shared party rice and everything. So on getting home that day, his dad was so happy and proud of him. Then at night, I think the neighbor's house, one of the kids there was having an asthmatic attack. So they now be like, thank God, we have a new doctor in the neighborhood. Go and call Dr. Jones. Go and call Dr. Jones. This is a child is having an asthmatic attack. Dr. Jones, when they called Dr. Jones that our child is sick, he got to Iran, he was going out that fresh graduates now. He got there, he saw that it's an attack. He said he got confused. He could not utter a statement. He did not know what to do. He did not know what to say. He was just all like, God. what exactly is going on the first day of graduation. So summarily, his dad understand what was going on and immediately picked the queue, carried the child, put in the car, and they started driving to the hospital. So he said that event always on. He was a consultant as at the time he was teaching me. So he said that event always haunted him all the days of his life. But it took a year. It took some years before he was able to settle down and relax. That okay, what could I have done differently in that event of that day? So sadly, even as a consultant, looking back and thinking about it, asthma is one of the most terrible conditions in which, as life threatening as it is, if not appropriately dealt with within the next couple of minutes, there is almost little to nothing we can do in terms of first aid at home that you can do for asthma. I'm sorry, I know that's not what you want to hear. And then you're expecting me to give you some home remedies, some things you could do at home that will help a child get better with asthma. There's something you can do. I'll get to it, but I mean, it's not one of those conditions that you have a home remedy somewhere that you do, you activate, then the person will get better. Okay, if someone collapse now, you can raise the person's leg. If the cause of the collapse, the syncope is cardiovascular, raise the leg up to increase venous return back to the heart. That might help if it is as a result of hypotension. There are some tricks you can use for different conditions, but I mean this one in particular, asthma, there is no trick. There is just only one thing you can do. The first thing is, okay, so a child having asthma, go straight to the point. A child having asthma, first, or an adult having asthma, tell the person to calm down. But how you calm a child down, though, is in God's hand. So tell the person to calm down, to relax and have a seat, then take deep breath. Deep breath in, out, in, out. And they should keep doing that. Then while they're doing that, look for their inhaler. This is the point I'm trying to make. As an organization, as an NGO, the greatest thing we can do for people having asthmatic attacks, apart from talking to them and sensitizing them of some of the triggers, is making sure that every household with a child that has asthma or with an adult that has asthma has an inhaler. Apart from that, then you can go and research. Please, in case you find something, I'm also open to learning. I'm not aware of anything that one can do that is like home remedy that you can take, or maybe they will say drink so water, drink orange and lime, do this, do that. And that's not the time to feed them. By the way, it's very very dangerous. A person can choke on whatever it is they're giving them. So food is the least of the concern by at that particular. Of course, nobody will give any child having respiratory distress food. To the picture, if you've seen the picture before, you would not want to give them anything by mouth. All you're after is for them to breathe. So imagine trying to hold your breath. Have you heard this saying before that nobody can kill themselves by holding their breath? There's no suicide by I want to kill myself, so I'm going to hold my breath. You can't do it. Your body is going to overpower your will. You can try it. Hold your breath now. At a point, your body is going to say, Chairman, it's like your will is very, very dangerous and you want to kill us. We will not let you kill us. So your body is going to defense mechanism will kick in and you will just start breathing. You can't hold your breath and use it to commit suicide. It's not possible. So that's what I'm trying to say. Inhalers are the most important things to have in the household where they have someone having asthma. So the first thing to do is to counsel them to get inhaler. So if there's anything we are going to give them, more than rice, more than indomie, more than anything, to make sure they have inhalers. So if there is a way that could, if okay, let me I'll get back to that. So inhalers are the most important thing you need to give someone having asthma. Apart from calming down, when you calm them down, it prevents it from getting worse, but it will not reverse the asthmatic attack that is going down, that is going. So I'm being very, very plain with you here. They need inhalers. So if those inhalers are in place, now you need to teach them proper inhaler technique, which involves anytime you have an inhaler, make sure it has not expired. Check the expiry date before purchasing any inhaler. That's one. Number two, shake the inhaler very well. If an inhaler has a mouthpiece, remove the mouthpiece part of the inhaler. After that, shake the canister of the inhaler. After shaking the canister, press a puff out into thin air to be sure that there's something inside. So press one into thin air before you put inhaler in the mouth and press it. Meanwhile, there's nothing in the canister. You're just putting empty thing in the child's mouth. So press one out to be sure it's there. Okay, when you're sure that something white is going to come out from the mouth, you're sure that has come out, put it in the mouth, tell the person to calm down. This is where the calming down part work. Calm down, take slow deep breaths, take slow breath in and out. Then press a puff into their mouth, tell them to close their mouth, and they should not hold their breath. They can hold their breath for 3 to 4 or 5 seconds for as much as they can. But I mean, so once they do that, they can open their mouth and do that. Then you can repeat the process again. Let me take this inhaler technique again, delivery system. Take your inhaler, shake it, make sure it is not expired. Shake it very well. Press a puff into thin air. Put it into the person's mouth. Press a puff. Take the person to take a breath in, remove the inhaler from the mouth, close the mouth against the one that is in your mouth, take breath in and out, and that's it, really. So you can repeat this thing again the second time. The person should start feeling better gradually. It's one of the things that is magical, really. You see hypoglycemia, you see asthmatic attack, once you have the right thing to use for them, it's like magic. The person lights up for you. So put the inhaler in the to put the inhaler in the mouth and deliver the drug is salbutamol that is inside the inhaler. So we have different types of inhaler. So we have the blue inhalers, we have the brown inhalers. The blue inhalers are called the relievers. So those ones there, if someone is having asthmatic attack now, how do we relieve it? Give the person the blue inhaler. It's made up of a beta 2 agonist, salbutamol. So what that basically does is it goes to relax the pipe that takes water to the pumping machine. So that's that. Then we have the relievers. We have the preventers. Sorry, that's the blue. Let me take that again. We have the blue inhaler. We have the brown inhaler. What we want to use to relieve an acute asthmatic attack is the blue inhaler. It's a reliever. The brown inhaler is made up of steroids. It's a preventer. It's to prevent further attacks of asthma. So blue inhaler, brown inhaler. The blue inhaler contains salbutamol. The brown inhalers contain steroids, or a combination of steroids and salbutamol. So the brown inhaler, what steroids basically does is suppresses some immune system and some part of the immune system, and prevents you from having an attack, because asthma is an hypersensitivity reaction to a particular allergen. So the steroid suppresses the body's immune system from reacting to those allergens. So that's what it does. So blue inhaler, brown inhaler, those are things to use to relieve an attack in an acute situation. Please, so far, am I making sense? I just need the comments from the comment box. Any questions so far? Any query? Are we understanding? Any clarification? Just the comments in the chat box is going to help. So, okay, all right, thanks. So, yeah, that's that's the first aid, the only first aid to asthma. That's the only thing we could do to help relieve it. So now the body treatment of asthma is not ending at the point of giving them the inhaler. You give them the inhaler, you see them light up. And please note, let me say what to do. In a situation whereby you give inhaler and the child is not getting better, the next thing is that to start running. Let's start going to the hospital. When they get to the hospital, what they might be willing to do is to nebulize. There's something we call nebulizer. So it's just like a white transparent plastic that's going to be put over. That one deliver, inhalers, you're putting it in the mouth, pressing the puff and letting it enter into the chest. So we can do well after this session to not even do his assignments very well. He not do his, have you neck pressure, brother? Thank you. Maybe he's trying to relieve the airway obstruction through the neck. A method. His technique should be studied. Really, his technique should be studied. So, but anyway, yeah. Immediately after, if you see that a child is not getting better after applying the putting the inhaler, please, hospital is the next thing. Things that they want to do in hospital, they may want to nebulize the child with salbutamol. Nebulization delivers more. So the mask used in nebulization is going to cover the nose and the mouth. You know, you are putting your own in the mouth alone. So they make sure they deliver with nebulization delivers it through the nose, through the mouth. So there is more delivery to the lungs and to the airway by nebulizing. That's one. Then in case that doesn't work, the hospital is equipped for some things to do. So we start thinking of intravenous steroids to relieve the airway. So in which they'll be considering giving the child some hydrocortisone or prednisolone. Those are steroids. They would help. So those cannot be achieved at home. So hospital is the next thing. That's why I say there are some plenty things that in emergency situations, some emergency conditions at home, there are a lot of home remedies and things you can do. But sadly, asthma, is it at home you'll be given hydrocort or ipratropium bromide or nebulization? So yeah, it's worth noting that people are getting aware that so there's something called the spacer device. If you it's just try and check on YouTube. Please hope we are noting this down. Proper inhaler technique, or please the moderators, maybe we can project a video on. I would send a link on of maybe a good video I would recommend to be projected on proper inhaler technique. Another thing that could be used to help the inhaler deliver better is something called a spacer device. A spacer device has a face mask. Though I never saw one in Nigeria until I was preparing for exams, some exams. That's when I now started hearing spacer device, and that was when even I myself was seeing it. I think it's worth mentioning. Let me not assume. Maybe things may have changed and it may be readily available. So a spacer device works like a nebulizer, but not a nebulizer. Nebulizer has a pump that pumps the thing into the person's nostril. So what spacer device does is you connect your inhaler to a face mask and put the face mask over your face, like you see in movies, all those gas masks. So the spacer device has a mouthpiece like that, but not as big and scary as gas mask anyway. So you connect it to your face, then you puff, you press a puff of the inhaler, the salbutamol itself, into the chamber of the spacer device. Then you make a airtight seal of the mouthpiece of the spacer device over your nose and mouth. Then it delivers it. Then you just take deep breath in and out 10 times. And that's it. It delivers more to the child than a traditional inhaler would have delivered. So that's a spacer device. That's just by the way. If you check and it's readily available or it's something we want to invest in, yeah, it's something really, really good. So yeah, so I've talked about taking the child to the hospital. After, if you use the inhaler and the child gets better at all, beautiful. The next thing is that's not the end though. Make sure you identify what's the trigger for this particular asthmatic attack in this child. Because if you don't identify the trigger and remove it, what stops the child from having another attack in the next 4 hours, 5 hours, 6 hours? So what triggered this particular asthma in this child? How do we remove it? Is it pollens? Is it dust? Is Mama John frying something? Sorry, Mama John. Please hope there's no John in the house. I'm sorry, I just used to speak. Is Mama John frying something? Is she frying meat for Papa John? And John now inhaled the thing and John could not breathe. So please, it's good to identify the trigger. So those are just some of the things. I think at this point I would like to stop so as to take some questions. Then from the questions, I may even remember some other things to add. So for the purpose of outreaches anyway. So I think we've talked about just a brief recap. We've talked about asthma in layman terms. We've talked about the triggers. We've talked about brief etiology, what causes it. We've talked about how to identify what are the signs and symptoms you see in someone that is having an acute asthmatic attack. We've talked about what to do in that situation. We've talked about in case what you did is not working, what's the next thing? Run to the hospital. We've talked about identifying the particular trigger, and yeah, I think let me take a pause here and entertain questions if there are any. So thank you, everyone.
Wow, wow. Thank you. Thank you very much, sir. My jotter is almost full. My full jotter, like a whole jotter is almost full from all what I've learned today. And that's not a joke. It's just to emphasize that we really learned a lot and we really appreciate all of that. Thank you so much. Before we move on to the question to the QA session, I just want to say that the link to the YouTube videos will be sent to the group. We're going to make sure we send at least three different links so that if you don't fully understand one, you should understand another. So we'll send that to the group afterwards. And so, just like our guest speaker said, let us send in our questions. Please and please let us send in our questions because, of course, we are going to teach people and they would also have questions for us. So if you know there are questions or there are some things that you're not so clear about, here now is the time you can ask those questions. Thank you. You can raise your hand to signify. Okay, I can see some hands up already. All right. We're going to be taking it one after the other. Okay. Um First, let's have Pomile. Pomile, let's have you. I saw your hand first. Let's have you. Thank you.
Hello, Dr. Olaide. Thanks
Yeah.
for your laugh. I'm not sure how that's going to work. But yes, thank you so much for the session so far. My question is regarding the genetic basis for asthma, right? So, is it possible for someone to develop asthma at an earlier age? And can too much exposure to some? I know you said some of these theories are not exactly true and they have a lot of criticisms, but exposure to something like asbestos for people working in, let me say, mining industry or some gases, can it start things similar to asthma in people, even when they were not born with a gene mutation or with a gene, or can a gene mutation occur? Just something around that.
Okay, all right.
Number
Thank
one.
you very. Okay, sorry. One, ten.
Oh, do you want me to
No, no, no. Ask the
continue?
second one so that we'll answer it together. And maybe from answer, I would like to be answering as you're asking, so that maybe from the
Okay.
answer I'm providing, maybe that would have answered the question of the next person and prevent the person from asking the question. If you get what I mean.
Okay, all right. So, two more questions. The second one is you've spoken about it a bit. So, I just want to be sure of the definite test for diagnosing asthma. You mentioned spirometry. I want to know if there's any other test that can be done um to diagnose as asthma is someone that currently does not have, so more like a screening, not just someone that is already having the crisis. Then the third question is generally about other respiratory conditions that can be as dangerous as asthma that we should watch out for in rural communities. Like, could you mention them and help us understand better?
Okay, all right. Thank you very much. I can see there are plenty, and so I'll be brief in my answers and just go straight to the point and not beat around the bush. So, first question: when people tend to have asthma, asthma can occur at any age in life. I've talked about the genetic predisposition to it, but when can someone, a child can, well, you don't diagnose asthma in a child of 1 year old or 2 years old. Pediatricians frown at that. Rather, we call it hyperactive airway disease. We may be seeing the signs and symptoms. This child is wheezing, having some breathing difficulties. We don't call it asthma. We call it bronchiolitis at that stage in less than 2 years of age. So before you diagnose asthma, the person will have passed 2 years of age. That's one. You don't say a 1 year old child has asthma. No, no, you will not hear anybody say it. A doctor will not say that. Let me put it that way. So before you diagnose asthma, 3, 4, 5 years of age, a 2 year old child will not even know that he's wheezing or not. And you have to do some symptoms. And the test you need to do to diagnose asthma, if you give the child instructions, so a spirometry basically involves checking the lung function. So to answer the second question is there a definitive test for diagnosing asthma? The name of the test is spirometry. Some blood tests will have been done before then, but they are not going to be. They are going to give us an idea of that. Oh, okay, 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 okay. This is supporting what I'm already suspecting. You can check the immunoglobulin E levels, so which is usually elevated in asthmatic attacks or people that have asthma. So, but not only that, it's not only asthma or hypersensitivity reaction that makes immunoglobulin E level elevated. Parasitic infections like ehrlichiosis and some others could raise the level of immunoglobulin E. So, but because it's a sensitive but not specific test, we do spirometry. That one is specific and targeted. It involves checking the chest, doing X-ray, checking the lung function, blowing air into a particular thing. So there's a way. There's something we call peak flow meter. Someone that is asthmatic, if you give the both of them to blow air into the peak flow meter is like a pipe. You give someone that is not asthmatic to blow air into that pipe, the meter will read. and the meter can get like 100%, which is good. But someone that is asthmatic or having an attack, if you tell them to blow air, the meter will not pass like 45, 50, 45 is dangerous, will not pass like 50, 70. Anything above 75, we used to discharge them that let the person go. If you don't have asthma, you blow into that machine, for example, it may show that it's 100%. You will see the gauge moving. It's like they say you should eat a box and they will weigh how much of force you were able to use to eat it. Some people will punch that box and you'll see 70 kg. Some will punch, you see 80, 90. So anybody like people that are non-asthmatic are able to blow air into that stuff and get to like 100. A asthmatic person, you'll see them around a particular range. So anything above 75, we discharge them and let them go home. So spirometry is the gold standard. There are some blood steps tests you're going to do before then, but spirometry is the ultimate gold standard. So, but spirometry involves blowing air, doing a lot of things that a child will not be able to do, hence making it difficult to label a child. A child will not be able to obey those instructions, and you can't help or augment it, or else your results will not be very, very certain. So, I hope that answers that part of the question. Regarding people being so asthma, there may be genetic predisposition, and yes, you can skip generation. Father can have asthma, son will not have, a grandchild will have. There is family history of it. So just the same way some diseases skip some generation. You understand? So the same genetic ways in which disease skips some generation is the same way asthma can skip some generation. So it can occur in maybe two grandparents behind, then it skips generation and is now manifesting in this child now. That could occur. It can occur when the person is 40, can occur when the person is 45, and it can occur as early as childhood. So it all varies really. Then things like exposure to asbestos, can it cause asthma? No. Asbestos can cause asbestosis. So we have occupational diseases. So we have farmer's lung, so people that are working in poultry. We have fanciers disease, bed fanciers disease. Also, all those we have asbestosis. These are all conditions that occur as a result of exposures to all these heavy chemicals, heavy hydrocarbons, and eventually in the long run damaging the lungs and causing fibrosis. When these things occur and damage the lung, it prevents the lung, it causes fibrosis. Fibrosis means healing with scar. So, and we know that a scar is not an elastic tissue that can expand like that. And lungs needs to be able to expand and contract to be able to be taking in oxygen and pumping it out the CO2. So when lung is already fibrosed and having a lot of scar tissue on it, it will not be able to do that. So the person will be having a lot of respiratory difficulties. There's something we call COPD, that's chronic obstructive pulmonary disease. In COPD, which is smoker's cough, normally oxygen saturation for people that don't have smoker's cough, we expect it to be about to be 95%. The amount of oxygen in your body wants it to be 95% and above. So, but someone with smoker's cough cannot achieve this oxygen saturation of 95%. So, if oxygen saturation of 88 to 92% is acceptable for that person, so that person is an asthmatic patient who will not have good oxygen. It does not mean anybody that has less than 95 is having asthma. No, it just means he may have other respiratory conditions. So, other respiratory conditions, we have smoker's cough, that's chronic COPD. We have asbestosis. We have pulmonary fibrosis, a whole lot of respiratory illness. But for the purpose of this discussion and for rural areas that we are going to, some conditions, respiratory conditions that could occur in our rural areas, we have pneumonia. That's a common one. We have croup, laryngotracheal bronchitis. But let's not go into all those ones. Let me just briefly say something on pneumonia. Pneumonia is a respiratory chest infection. So my grandma of blessed memory, I remember when we were growing up, when we were going out, Ola, wear sweater, wear sweater. We will not wear sweater. We are very, very stubborn. We will not wear sweater. So one day when I grew up and immediately in med school, I learned that pneumonia is not caused by cold. Cold doesn't cause pneumonia, by the way. It's a bacteria that causes pneumonia. So I just went back that day, intentionally was flashing my chest, triggering grandma to look for trouble. Grandma now told me that, cold, you catch cold, do you this, but too I'm well. I was like, okay, mommy, am I worried? Grandma, am I worried? Sorry, all of us will not be Yoruba. I'm remembering I get excited when I love my grandma. I'm grandma's boy. Sorry, guys. So let me speak in English. So I mean, grandma was like, put on your sweater. You are going to catch cold. I said, you've asked the question I've been wanting you to ask all this, grandma. Cold does not cause pneumonia. It is a bacteria that causes pneumonia. So all this time when I was growing up, you'll be saying wear sweater. You've been bullying me. It's not cold that will give me pneumonia. It's bacterial infection that will give me pneumonia. Grandma just looked at me and said, so you went to med school yesterday and suddenly cold is not causing pneumonia again. Let me tell you, before you were born, before I born your mama, cold has been causing pneumonia. Cold will continue to cause pneumonia even when you stop being a doctor. So Jesus will come. You cannot change it. It's code that will continue to cause pneumonia. It's not bacteria or whatever it is you call me. At that point, I gave up the struggle that now I can't convince this woman that code does not cause pneumonia. So, but anyway, that's just a story, by the way. I remember my grandma today. So, point is, some other conditions that you could see in rural areas, pneumonia, which is a bacterial infection, it's just that it gets exacerbated during cold. Cold itself does not cause pneumonia, but pneumonia gets exacerbated during cold, if you get what I'm trying to say. So, yeah, we have pneumonia. And some of the signs and symptoms you see in these people, you see fever, the child will be having temperature, the child may be having cough. The cough may be productive of sputum. The sputum, you hear things like the sputum is greenish, is yellowish, or is brown. So, chest pain, fever, cough, breathing difficulties, these are some common signs and symptoms of pneumonia. And the way to go about it is go to the hospital. They are going to order some bloods. They'll do a full blood count, check your inflammatory markers. They're going to order a chest x-ray. There will be consolidation of some parts. That's some parts. So maybe consolidation of some part, and you'll be given the appropriate antibiotics. So there's community-acquired pneumonia, which there are guidelines for. There is hospital-acquired pneumonia. And it's not only bacteria that causes pneumonia, by the way. Different forms. We have bacteria, viruses, fungi causes different types of respiratory infections. So, to answer Pomile's questions, other respiratory conditions in the area to tell them that we've talked about pneumonia, bacteria infection. Then after, I think I've answered all your questions, Pomile.
Mommy, are you there?
Yes, we are.
Okay, all right. So next person.
All right, thank you very much. Next we'll be taking Ebonoluwa. Ebonoluwa, please ask your question.
All right, good morning.
Yeah, good morning.
Good morning, and thanks for this class. So, this is my question. First of all, apart from recognizing triggers for asthma, is there any other like home remedies for asthma that we can like use for asthma patients? And the second thing is that during beekeeping, I'm an agric student, so we did beekeeping, and my lecturer said that the honeycomb honeycomb can be used to make candle wax for asthma patients. So in case we come across people that do not have money, like enough money to get inhalers and all that, can we like, is it advisable, or is there any other home remedies that we can like tell them to use?
Okay, all right. Thank you very much. My dear colleague Ebon, to the best of my knowledge, and from as at yesterday when I still checked before coming for this presentation today, a lot of things change fast in the current day and time. But to the best of my knowledge and from the information available to me till yesterday, I'm not aware of an home remedy. Please note, it may be limitation in my knowledge. That does not make it absolute. Maybe I've not checked enough. But I'm not aware of any home remedy or anything you can use at home to read, apart from the relaxation technique, telling them to calm down, reassuring them, making them feel better. And if you see things are turning for, while doing that, I would advise you be reassuring them on the car. If there is no inhaler at home, I would advise put them in the car and be reassuring them on the way to hospital. If the attack stop before you get to hospital, turn back the car and start coming back home. But don't reassure them. Don't sit down at home and be reassuring themselves if you don't have inhaler. That's what I would recommend anyway. So, but I'm not aware of any home remedy that could be done. That's one. Then number two, and I believe that if anything had been discovered, it will have been publicized really in a paper for people, because nobody wants anybody to die. You understand? So if someone has an home remedy that is working for asthma, I believe they should put it in paper out there that if you Google it, it should be something that would pop up easily and should have been used and should have been tested to have worked, and everybody will adopt it. We as doctors will, like, I work in the emergency department. I'm one of the doctors in the ED. It's annoying. Like the number of people I see per day, I would really be I remember I walking after first 2 days. I was like, is it that these people don't used to pray in this place or something? Why is it that everybody in the ED, in the emergency department, I'm sure you must have heard a lot of terrible news going on in the NHS currently about how everybody's overworked. Patiently, of course, the rate of migration increased to the United Kingdom, and so the ED are just overloaded and overworked. You can never finish the number of patients in the ED. You either you when you get to work, you are going to meet patients, and you can't finish it when you are leaving. When your shift is over, you leave people there for the next people to come and take over and continue. It's like that every single day, every day. It's not getting better because people keep coming in and all. So now the point I'm trying to make is that the system, they have designed a system in such a way that if you are sick and you're not very, very ill, you could call 111 and tell them what is wrong with them on phone, and they could advise you or direct you to maybe a pharmacist to go and get some prescription. There's a doctor on the end of the phone of 111 that takes the call and triage appropriately that, okay, you need to go to the hospital with what you told me. Oh, yours is chest pain. It could be an MI, myocardial infarction. Please go to the hospital. Oh, no, just go to the community pharmacist. Tell them to give you some amoxil or so, and you get to reduce the traffic. So this is the point I'm trying to make. If there's any home remedy for asthma, I believe this is the best time with the amount of traffic congestion we are seeing in the ED. This is the best time that people would be advised that, oh, asthma, please don't bring them to the hospital. Give them this at home, and they will be better. But to the best of my knowledge, I'm not aware of any. Is to use inhaler with a spacer device at home, and if it is not working, start call 999. Ambulance get to your house in the split of a second, start rushing you to the hospital. In the ambulance, they will start nebulizing you before you even get to the hospital. You won't wait to get to the hospital to nebulize you. The ambulance crew are trained to nebulize you and start rushing you to your hospital. So, I mean, I'm not aware of any home remedy. Now, talking about the honeycomb, my dear sister, there are a lot of things. I don't want to sound as if uh, I'm not a believer in some other forms of therapy that is not strictly the conventional medical practice. I'm aware there are a lot of things that are working. I mean, as I said, I'm a Nigerian. Come on, I'm a Yoruba guy myself. I'm a Yoruba man, and I've seen some funny, funny things. But sadly, if these things can be put or publicized in paper and tested against, like, let people stand up, speak up, and bring it to the international community for it should be replicable. You should not do something in Nigeria and it works only in Nigeria, and people in Spain cannot benefit from it, or Italy. No, something that you do, it should be replicable, and they say we tried it in so place and it worked also, and it will be generally acceptable. But some of all these things that we talk about are, why is it that it's only in Nigeria that is working? It's not working elsewhere when you tried it, and it's not even in the whole Nigeria. It's not generally acceptable. So to be honest, thinking about it, we've talked about triggers for asthma, that smoke, extremes of temperature. So if you make a bee wax and you melt it and use it to make a candle or wax that they light up for someone with asthma to do home remedy, it sounds rather dangerous to me, and something that may even exacerbate things rather than make a solution. But as I say, to be honest, I have limited knowledge about that. I really wouldn't know the constituent, but I would want to believe that if it's something that is working, it should have been in international papers, or the international community should have accepted it. And to the best of my knowledge, when I was still practicing in Nigeria, in Lagos, I'm not aware of. I would say I've had my fair share of practice in the rural area. I worked in Jos for a while. I've worked in Adamawa. I've worked in Ondo State, and I'm not in the state capital in all these places I'm talking about. I worked in the rural areas in Jos. I worked in Ondo town when I was in Ondo State. I should have I believe because I'm a very, very curious person. I should have come across someone that will say things like that and the rest. But if you try, just Google these things that I'm talking about and see people's review about it, and if there's any change, I wouldn't recommend that we advise mothers to do things like that, because if it's something that is even harmless, I would say, but something that involves it in Nigeria, where we are still trying to take people away from practices of anybody having epilepsy, is until recently we tell them to stop burning children. People with epilepsy, there was a time they put their hand in fire to wake them up. People that are having convulsion. I don't know who came up with that. We are still trying to stop people from carrying out those things, or putting cow dung or urine in their mouth. Well, you hear a lot in the hospital, really. Some funny, funny practices that you'll be like, where did these things come from? So please, maybe things that are not have not been scientifically proven or are not in the general world, if they bring it up, what we could tell them is that, to be honest, I'm not aware of this particular thing being working. What I could do is I could check it up for you, or I would advise you go to the hospital, and the next time you're in the hospital, maybe ask your doctor if it is safe, or your respiratory nurse if it is safe to go ahead with things like this. But I wouldn't recommend you do it and see the repercussion first before trying to ask. Try and ask first before doing it, and maybe ask them in a in a professional setting. That's what I would recommend. I hope I answer your question. Okay,
It's
thank you.
very
Hope you are not angry.
clear.
Please don't mind me. Oh. My knowledge is limited. I'm just talking within the scope of my own limited thinking knowledge. Please.
It's all right. Thank you, sir.
Okay. All right. Thank you. Please don't send me. Oh. My name is Ola. Let's call me Ola, please. It makes the conversation flow. First name, please, Ola.
All right. Thank you very much for that. Simeon, you're up.
Okay, so I wanted to ask, would you recommend steroid tablets during attacks? Because I know that inhalers do not change or cure the symptoms. So would you recommend it?
Okay. Thank you very much, Simeon. Inhalers do not cure the attack, but steroids during the attack is of little or no benefit. So before a drug would work, you need to consider the onset of action. You need to consider the peak plasma concentration. You need to consider the duration of action. So if you give someone a steroid during the attack, look, let me rephrase. Steroids during the attack in tablet form. If you don't have an alternative route of giving any other medication, then yes, you can consider 40 milligrams of prednisolone tablets. You understand? But if there are other routes, like you've used inhaler, salbutamol, and it's not working, you renebulize. By the way, you can use this. You can nebulize someone like back to back. It's not a one-time thing, by the way. So you can use salbutamol back to back, back to back, back to back, while getting alternative therapies. So if you use salbutamol, the guideline says. So there are guidelines for these things. First line of action is give the person salbutamol. If you nebulize salbutamol multiple times, the person is not working. Nebulize 500 micrograms of ipratropium bromide. You do that, is not working. Set an IV line for the person and give the person IV steroids, hydrocortisone, 100 or 200 milligrams. Do you understand? So that's IV steroids because IV has fast onset of action. And you are talking about if you're talking about relieving the person's symptom in the immediate as it is, then IV steroids is going to go a long way. And the person is going to enjoy the benefit of the IV steroid for over a couple of hours, not even in the immediate. But if you're giving oral steroids, anything that goes through the mouth, I want you to understand that it goes through something we call the first pass metabolism. First pass metabolism is that it goes through your mouth. After the mouth, it gets to the gut, to the GIT. From the GIT, it gets metabolized and broken down. From being metabolized and broken down, the blood vessels around the GIT absorb the drug from the GIT and take it to the liver and through enterohepatic circulation. On getting to the liver metabolizes and breaks down these drugs. Some part of it are lost to the liver, while some parts make it eventually to the systemic circulation. So that's when we talk about that's what they're talking about when we talk about the bioavailability of the drug. The particular percentage that make it to the event is for any drug you take, any drug, it go well for not any drug, not all. Most drugs go through this first pass metabolism, and eventually the parts that make it to systemic circulation, that's what they talk about their bioavailability. So the time it takes for all this to occur, that's why if you take paracetamol, it's not immediately it numbs your pain. It goes through all these things before start numbing your pain, about 30 minutes, 1 hour, and the rest. So that's what brings about the onset of action and stuff. So if you're using it for immediate abortion of that attack that the person is having now, I would advise all those they are called short acting beta agonists, like salbutamol, ipratropium. Those are the things to use in the immediate. But to prevent, yes, steroids. If it's to prevent further attacks, steroids, we weigh the risk and benefit of steroids. Steroids have a lot of side effects, by the way. Osteoporosis, immunosuppression. It puts you at risk of coming down with some infection. Because what steroids does is that steroid is a sledgehammer. It knocks the asthma is an hypersensitivity reaction. Your immune system your immune system is acting up. That's what's occurring in asthma. Steroids knock down the immune system and covers everything. So as the immune system is being knocked down, preventing you from having asthma, it's also preventing you from having every other thing, not only asthma. It will not just go and catch the airway. It prevents you from having all sort of things at that point in time. But it also, because it's knocking down the immune system, so small opportunistic infection that your immune system will have otherwise undo are at risk. That's why if you're using steroid inhaler, for example, one of the risk factor or things that commonly follow steroid inhaler is that you're at risk of having fungal infection in your mouth, oral thrush, because the steroid is immunosuppressant. That normally you won't have thrush in your mouth if you're immunocompetent. You understand? So, but because you're using steroid, it suppresses the immune system. you come down with some opportunistic infection. However, should we not use steroid? No, that's not what I'm saying. I mean, we start steroids when the benefit outweighs the risk. So a child is coming down with asthma, coming to see me in the hospital every day, every day, every day. No, I'll consider steroid because it's affecting with that child's activities of daily living, and the child cannot go to school. Small time in school, they say he's having an attack, they bring him back. So what's the point of me not giving steroid when he's affecting this? It's not, this child is not living the life to the fullest. So, and there are criteria. So that's why I say there are guidelines for these things. So if this child meets so criteria, or this adult meets so criteria, so prescribe steroid is already affecting with the person's normal day-to-day activity. So for immediate abortion of it, yes, give the beta agonist. But for further prevention, yes, steroids can be used, and there are different delivery methods. It mustn't have to be there are steroid inhaler. That's the brown inhaler I talked about. There are combination of steroids and the salbutamols. That's, I'm sure you must have heard serotype inhaler. Those inhalers that used to look like circular. You know, normal inhaler looks like vertical with a small L, like L shape. That's what the salbutamol looks like. But still, some of those steroid inhalers, not all, they look circular in shape. They mostly come out. They are metered dose, look circular in shape. Then you just put it around your mouth and it looks like you're. So I hope that answers your question, Samuel. Simon, sorry. Okay.
Yes, it did.
Okay. Thank you very much. Ebonlua, your hand is raised again. Let's have you.
All right, thank you. If there's like a cure for it, is there any cure for asthma? Is asthma curable?
Hmm. God bless you, Evan. That's a very good question. So, well, concerning a cure for asthma, I'm not aware. It's difficult. It's a difficult question to answer straightforward. But I'll try to address and give you, make you understand some things. So, regarding asthma, the multiple factors that are involved in the pathogenesis or in the etiology in causing it makes it difficult to target one thing and say we want to cure it. So, yes, can someone outgrow asthma? Are there people that have had asthma before in the past and they no longer have attack in the last 5, 10, 15 years? If you would call that a cure, then yes, you understand. At times we call it remission, or we can say the person outgrow it. Oh, he's not having attacks again. He was having attack as a child, but since when he clocked 20 years, you will hear that he has not had attack in 5 years, in 10 years. I won't call that a cure because, well, it can come back. I've seen someone that said he had asthma as a child. Then when he was 20, he just stopped having attack. But the day he clocked 45, he had an attack and he started having it again till old age. So it was free for a long period of time. So that's why if to say a cure, is there a particular medicine that I'm aware of that if you take, you will not have asthma? You will not even have to take inhalers or anything again. Your asthma will just go. No. But is there something, are there things you could do to prevent frequency of attacks? Yes. Are there gene therapies that you could do that would prevent, that will cure the asthma? None that I'm aware of. Let's pick sickle cell disease, for example. Sickle cell is one of the most understood disease. We know what is wrong in sickle cell. An abnormal globin chain. We even know the position 6 of the beta globin chain is what is causing sickle cell. But yet, theoretically, we've been able to say if you carry this particular lysine replaces glutamic acid in that particular position, how about we do some gene modification and replace that lysine, take that lysine out and put glutamic acid back into this thing? Theoretically, it should work, we know it, but yet there is still no cure for sickle cell except stem cell transplantation. Anyway, that's a cure. You can do stem cell transplantation and yeah, the person is going to be fine. So, well, of course, on different medications for immunosuppression and stuff. So there is no direct answer to that. That there is if you're asking if there's a tablet or injection that you can do that will cure asthma, no, there is none. But can it just spontaneously stop? Even that medicine will not take glory for it. You understand? Like you're not taking anything, you just do not have those attacks again. Yes, there are people like that. They've not had attacks in 15 years, in 10 years. So I hope that is close to answering your question. I know I know it's not is I'm sorry, it's not a yes or no answer. But there is no direct cure. There's no medication or injection or surgery that you do that will cure it. No, but it can spontaneously stop. And there are immune therapies, immune modulating drugs that can modulate the immune system that are not steroids, montelukast and the rest that could modulate the immune system and prevent frequency of attacks. Thanks.
Thank you.
Yeah.
Thank you very much, sir. I'm sorry. I want to ask one more question, like the last question.
Okay, yeah, sure. Please go on.
Okay, so like you said, there's a strong disposition to genetics when it comes to asthma. But if a pregnant woman like that knows that it runs in their family, is there anything they can do to prevent the child from having that like asthma?
Sadly, no. This one is a straightforward one. Unlike the last question, sadly, no. There is nothing you can do really in pregnancy to prevent the child from having asthma. Because the truth is, you can't even predict if that child is going to have asthma. It's easy to solve. The first step towards solution is being able to identify the cause. That your father has asthma, then you, the mother, has asthma, your husband has asthma, does not guarantee that your child is going to have asthma. It just increases the risks and the chances of your child getting asthma, but does not guarantee that that child will absolutely have asthma. As I said, genetics is a very, very funny thing. How would you explain, father, everybody has been fine, 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 and suddenly they gave birth to a child that is albino, and everybody start wondering that, okay, how did they give birth to an albino child? You understand, the parent are. But meanwhile, if you trace the lineage, maybe fourth generation, you understand, down the line, that they are not even aware of a grandfather they never met had it. So the gene just decided to remanifest at that particular point in time. Do you understand? So that's why it's difficult. There are some things that you will see and you will say, oh, this person stands a high risk of having this. The chances of this thing occurring is high, but you cannot absolutely say that this will definitely occur in this child. The only thing that I'm sure, or there are many things, but the only one that comes to mind now that I can remember now is that I can confidently tell you that if SS and SS marry each other, they will give birth to SS. That I can tell you. You understand? But apart from that, I'm not for asthma. No, I won't say there is no way. If there is no way of predicting or identifying this thing, there is no way of curing it. If you get what I mean, you need to be able to identify it to be able to treat it. All right. So, any more question, please?
All right. Do we have any other questions? I also have my question, but if we have any other question from the audience. Okay, let me just go straight to my questions. I have two questions actually, and the first one is following the teaching. You mentioned more of a child, and all. So I wanted to ask and be sure. Can we say that asthma is more prevalent in children than it is in adults? And if that is it, if there is there any reason for that? That's the first question. And now my second question is closely knitted to the question formally asked earlier. All right, after the establishment of the fact that it is linked to asthma is linked to genetics. Now, I remember that you mentioned that sometimes people do not even experience it until they are grown. So, can we then say that the alteration is there, is present, but it doesn't manifest? Sometimes it doesn't manifest early, and then it manifests later. Can we then say that oh, it has been there, but probably something triggered it before the person now got to know, oh, probably I didn't know I had asthma all this while. So those are my questions. Thank you very much.
Hmm. Thank you. That second question is very brilliant, and it requires some thinking. But let me start with the easy one. The first question. So, eh, please, could you? Sorry, I suddenly forgot the first question. This I got excited about the second question and I forgot the first question. Sorry. Please, could you remind me again the first question?
Oh yes, I
Okay,
said
yeah, I
that
remember. Sorry, I remember now. Children, whether it's
yes,
exclusively children
and
that
how
have
it
gender prevalence. Yes. So
mhm.
about that, sorry, I kept emphasizing on children because I'm sorry, I like kids. That should not be the presentation should not be biased. I like kids, and you are the at-risk population. It's likely that an adult that is having asthma will know he's having an attack, and I believe adults have started enjoying life small, small, so they don't want to die. They will know even small money they have instead of buying recharge card, they will go and use it to buy inhaler and keep it in the pocket and be able to save themselves. So that's why it seems as if the presentation is focused more on children. It's because they are at risk population than adults. That's why I keep saying children, children, children. And it's children that used to grow up to become adults. So if you don't take care of them or take care of the asthma in them and it kills them, they will not even grow up to become adults. Someone that is having asthma as a child before getting to adulthood will have learnt a lot of things, a lot of some of all those triggers before getting to adulthood, and hence the person is going to be good. So yeah, Children, is it only children that have asthma? No. It's because they are the ones that are at risk, and they are the ones that will not. All children know how to do is just cry. If they are hungry, they will cry. If they are sad, they will cry. If you beat them, they will cry. If they want to take anything, they just used to cry. Cry is the only thing they know how to do. Sorry, let me tone down. I mean, they cry a lot for a lot of things. I can't express themselves to say this is what is wrong with me. You understand? So that's why I keep emphasizing on them so that we pay special attention to them to be able to be. Adults will tell you that I can't breathe. I'm having breathing difficulties, stuff like that. But kids will not be able to. So that's why. About the prevalence, children to adulthood, I don't have the data really about the prevalence of this condition in children or adulthood. But really, I would say it can occur equally. But no, I don't have any value to quote, to be honest with you, about that. So, but yeah, I just keep focusing on children because they are at risk. That's just a simple reason. Any other special thing. So then about someone not having asthma all this while and suddenly developing asthma, let's say at age 20, 21, 22, could it be that there was a trigger that triggered that particular thing at that particular point in time? To be honest, it's a tricky question and I don't have a straightforward answer for it. Someone that's not been having asthma as a child that suddenly developed asthma at 30, at 25, what made him to develop it at 25 and did not develop it at 5 years old, 6 years old as a child? It's a difficult question to answer. To be honest, it's a difficult question to answer. It could be that there was a trigger at that particular age that the person would not even be able to identify that, okay, this is what made it to start occurring at this point and it was not. And again, there's something we call sensitization in medicine. So most of the time, if you have someone that is going to be allergic to something, the first time the person is exposed to it, the person is not going to have a bad reaction. The second time is going to be more terrible than the first, but will not be the point I'm making is that the more a person gets exposed to a particular antigen, the higher the chances of having a very, very terrible attack to occur someday, the higher the chances increases. So let me give you an example. There's a condition we call erythroblastosis fetalis. That's hemolytic disease of the newborn. It's a situation whereby an O negative. Sorry, let's not ask question about this particular thing now. Ladies that are O negative getting married to guys that are O positive, for example, have at risk of giving birth to a child that are O positive, right? Fine. So the child is most likely going to be O positive, or the chances are there that the child will be O positive. So the child is O positive, mother is O negative. If that woman carry that child for the first time, it is not a problem. The child is not going to have anything. But subsequently, if she have the second pregnancy and there has been fetal maternal hemorrhage from the first pregnancy, the chances that she may be having stillbirth in subsequent pregnancies are there. Do you understand? She's carrying a positive child. She is negative for rhesus antigen. So the first time she carried that pregnancy, she was able to succeed because her body has not been sensitized and the body has not produced plenty soldiers, immunities to fight that particular positive antigen that the child got from the father. So that child is going to escape. Subsequent pregnancies, the baby, she can be having stillbirth. It's a possibility that she will be having stillbirth. You understand? So that's why there is a solution for that, of course. A rhesus negative mother should go and take a particular, and every pregnancy she will take a particular injection called Rogam. That's rhesus antibody, is to neutralize all those positivity she gets from that particular child. You understand? To prevent it from occurring in second pregnancy. Now, let me link it to asthma. Why I went to this example is that the first time she's pregnant with a child, the child came back successfully. But subsequent pregnancy that she may be having may be stillbirth because she has been sensitized. So if you are exposed to something the first time, it will not harm you because it's new to your body. Your body is thinking about it that, okay, is this thing bad for us? Is it good for us? Should we fight against it? Should we not fight against it? But the time it takes to have the second child, the body has decided fully by that time that this thing is an antigen, it's a foreign body. Any child this woman carry that is positive, like this antigen are already in existence, antibodies are already in existence in the body that are ready to fight that child, and that child will be dying. You understand? So that's that. Now linking into asthma. The first time the person, maybe just an hypothesis, which is the logical one. The first time the person is exposed to those antigen, the sensitization are occurring, but they are not up to the trigger potential that would trigger a huge asthmatic attack. So that person has been gathering a lot of sensitization over time. You have been having swelling, small. If you understand the pathogenesis of asthma, you understand how you must have been exposed to these triggers before you suddenly now have an attack. It takes a lot to have an asthmatic attack, really. It is not the first time you ever get exposed to that thing that you have an attack. No, you must have been exposed to that thing before, consciously subconsciously or knowingly or unknowingly, any which way, you must have been exposed to it before there is one that will now eventually trigger that attack, and you now start having the subsequent attacks. So maybe those people that used to develop it at 20, it is safe to say that they may have a very, very high threshold for a trigger. So it took them that long, those number of years to develop, to be, for the body to decide that, okay, this thing is an antigen, let's start acting against it. Do you understand? I hope this answers your question. It's just there may be other rules and other explanation for it, but this is actually what I just told you now is scientific and it's medical, really, and it's logical. But I believe there may be some other hypothesis to it.
Oh, very clear. Thank you very much for the answers. I really appreciate that.
Okay,
Okay,
thank you.
this is another opportunity. If you're on the call and you have a question that you want to ask, please put your hands up. All right, I take that as there are no more questions. Thank you very much, Dr. Ola. Okay. Yes, thank you very much, Dr. Olaide. And what are we saying to him? Audience, what are we saying to him? You can unmute your mics, please.
Don't worry. I
Thank
think.
you, sir.
Oh, thank you, everyone. Too. Thanks for the privilege. It's an honor to be among you guys to be able
Thank
to.
you.
Thank you. It's an honor to be among you guys to be able to let's rub minds together and share little knowledge amongst ourselves. And I hope and pray that the outreach you guys are going for to be a huge success. And yeah, God will go before you and make it easy. They will ask you questions. I pray God will grant you understanding and the wisdom to be able to answer them correctly and appropriately. And yeah, to be able to help people in situations like this when they need help with asthma or any other respiratory illness. Help is not only in what you give them, it's even giving them advice of, oh, Charlie, go to the hospital. So stand rest. That's a very, very good. That's the best help you can give some people regarding their situation, really. So, like, yeah, I pray and hope it will eat success. So, thanks everyone too. Thanks to everyone. Thanks for the privilege. I'm
God
honored.
bless you.
Yeah.
Thank you very, very much. Thanks for the prayers also. I'm sure we are going to give you the reports after the outreach. All
Okay.
right.
Okay. Yeah.
The next thing we have on our agenda, I want us to I want to recognize the presence of a representative from our partner. Remember, I mentioned that this is a collaborative approach to tackling respiratory diseases. So please, I want you to put your hands together. When I say put your hands together, you understand what I mean. Use your chat box, right? Put your hands together. Odunayo Adubi, she's the representative of South Africa. Thank you very much for being present. We appreciate your presence. Um, we'll be inviting our lead curator in the person of Pomile Ogunjemite for the vote of
Thanks for liking for joining us today on the session. Considering when we reached out to you and how enthusiastically you decided to join us, it's like something we are really excited about. More importantly, is the rich content that you have pushed out today. So you notice that I told you that you should get this called voicey. I used to have 21 people and more. That's because just sharing this with other people and people want to like join this session. I'm so glad that we learned more what body reach out. So thank you very much for dividing for making out the time. And we look forward to more beautiful relationship between you and Pioneer Meditation and wish you so much of best of luck in your career. Thank
Yeah.
you.
Thank you very much, Family. It's an honor. Thank you so much, guys.
Partner with us to get this done. So helps us in also attending their appreciation to you, Dr. Light, not just from Pioneer Meditation, but also from our partners. So it will be there some acting regards on behalf of the two of us to you. Thank
Yo, thank you very much, Family. Thank you. It's an honor to be here, and yeah, thank you everyone too.
you.
So
Thank
have a
you.
lovely day. I will leave now. Thank you so much. All right, guys. Bye.
Bye.
All right. Thank you.